lecture to upload afterwards, and by staying in the meeting, that assumes you're all right with that. Thank you. So there we are, we're now recording. Welcome to tonight's lecture. Thank you for coming, and without further ado, I will hand you over to Orlaith.
Okay, yeah. So I'm Orlaith, fifth year medical student. Here's my email address. If you have any burning questions at the end, feel free to email me. So today we're going to talk about renal physiology and bladder control. Our learning points today are going to be the kidney, thinking about in a systematic way from proximal to distal how the cellular function relates to its overall function, because if not, the kidney can be quite bitty. So I think it's good to think of that bigger, the bigger functions. And then we'll focus on the regulatory processes of salt and water balance. And finally, talk about the pharmacology of diuretics as they relate to the physiology. Then we'll briefly look at the bladder, just the basics you need to know in the anatomy and the two drugs which are used when there's dysfunction. So if you just want to start off by logging into Socrative, I'm just going to launch the quiz. Okay, let me know in the chat if you can't access that. But we're just going to start off with a sort of general question about some of the hormonal functions of the kidney, which we won't really cover. So which of the following are functions of the kidney? So I'll give you a minute to answer that. Okay, I can see there are no students currently. If anyone participating has trouble getting onto Socrative, please do let me know.
I think looking at the chat, they're just trying to log in. It will probably be a moment.
Okay, grand. You can select several options. Okay, so I'm going to go ahead and show the results for that. So the kidney is involved in vitamin D activation. So vitamin D is involved in bone metabolism. Renin production, yes. Erythropoietin secretion, that is the signal to increase the number of red blood cells. However, it does not produce angiotensinogen. It's the liver that produces angiotensinogen and the kidney that activates this angiotensinogen through the renin enzyme. Okay, so this isn't core, but I think it's nice to think about what happens when the kidney doesn't function so that we can understand the physiology better. So if someone has chronic kidney disease, they might present with osteoporosis because vitamin D isn't being activated as much. They might present with an anemia because erythropoietin is not being secreted. There would be edema as well because of this dysregulation of the volume balance. Metabolic acidosis because the kidney is continually removing acid from the system. And uremia because urea is obviously leaving with the urine. And hyperkalemia because the kidney is pumping out potassium when it's functional. So that's just a brief, broad overview. Now we're going to go into some more specifics. So the blood entering the kidney is accounts for 25% of the circulating volume. So that's quite a significant amount, which is equating to 625 mils per minute of renal blood flow. Of this, 125 mils about is filtered into the nephron, into the nephrons of the kidneys. And a formula you would need to know from the syllabus will be the proportion of GFR to renal blood flow. So that's the filtered fraction. How much is of the fluid reaching the kidneys is actually entering the nephrons. So we'll go back to Socrative for our second question. Again, you can select multiple options. Okay, we'll show those results there. So yeah, high ANP levels would increase GFR because it's a natriuretic peptide and it's trying to get loads of salt out, so loads of flux through that filtration apparatus. And constricting the afferent arteriole would actually reduce the GFR, whereas constricting the efferent arteriole would increase that backlog of pressure so that the GFR would be increased. I've just sort of illustrated this setup of the kidneys, which is quite special, where you have two arterioles surrounding the capillary bed, and this allows for selective regulation of the GFR and the renal blood flow, because, for example, if you wanted to reduce the GFR without compromising the renal blood flow, this is possible by selectively controlling the afferent and efferent arterioles. So here's another little point to remember. Mesangial cells contracting would actually reduce the surface area, and so this would reduce the GFR. And as I mentioned, the arterioles setup is quite specific to the kidney. So now we're going to look at the Bowmans Capsule. There is a high driving force to filter the filtrate into the capsule space. So what's specific about this setup is that there is a high ultrafiltration pressure. This high ultrafiltration pressure is because of this afferent and efferent arteriole setup, which doubles the hydrostatic pressure of the capillary compared to other capillaries in the system. There is a little bit of back pressure from the filtrate, and that's subtracted. And there's also the oncotic pressure from the capillaries, which is drawing fluid back into the capillaries, but these are much less significant than that high driving force of the hydrostatic pressure. The high surface area of the glomerular capillary is because there is all this convolution, high surface area, and they're also allowing a lot of fluid through because of the permeability. So this whole picture generates quite a high flux. There are means of controlling the GFR very tightly. So locally, there is auto-regulation. So there's the TGF, which I'll explain in the next slide, and the myogenic mechanism of control, which is where stretch in the afferent arterioles will then be counteracted by the afferent arteriole constriction. So that's a very localized response. There are also vasoconstrictors and vasodilators, which will alter the GFR. Angiotensin will act more on the efferent arterioles, so increasing GFR. Catecholamines will act more on the afferent arteriole, and this will reduce GFR. Vasodilators include the two natriuretic peptides, which aim to increase GFR and increase that outflow of sodium. So the TGF is the tubuloglomerular feedback, and this occurs within the juxtaglomerular apparatus. There are 3 cells of note here. The macula densa is composed of specialized cells in the distal tubule, and these sense a high load, which is putatively through the high NaCl concentration. When this is sensed, vasoconstrictor, some sort of vasoconstrictor is released to reduce the GFR. Granular cells of the afferent arteriole secrete renin, and this will activate the renin-angiotensin-aldosterone system. And mesangial cells, which you've already mentioned, will contract to modify the GFR. So the JGA is a unit for autoregulation. If there's a high GFR, GFR is sensed and it's reduced back to normal in the small unit. So looking more closely at ultrafiltration, it was really first discovered when there was the micropuncture of the fluid, and it showed that basically it was similar to the contents of plasma, but there were no proteins in this fluid. So there must have been some sort of filtering process to remove those proteins. And this filtering process is occurs through the 3 layers of which are composed the filter: the capillary endothelium of the glomerular capillaries, the basement membrane, and the podocytes with their foot processes. So we're going to move on to the next Socrative question. Which is the most restrictive layer of filtration at the Bowmans capsule? Okay, so we don't have any answers yet. Oh, there we go. Okay, so that's correct. It's the podocytes. And basically, I've just put a little explanation here. The capillary endothelium blocks cells largely. The basement membrane is negatively charged with its glycosaminoglycans, and that restricts the passage of large solutes. But then it's really these podocytes with their slit pores, which are covered by diaphragms, which repulse all the other things with their negative charge. So there are certain limits on what can pass through. The negatively charged things can pass. Things which are above a certain size, above a certain weight, and of a certain shape also can't pass. Okay, so clinically, how is GFR measured? This is a really important measure to have in clinical practice. So it's done through measuring creatinine. However, creatinine is not only filtered freely, it is also slowly secreted. So this leads us on to our next question. Does creatinine underestimate GFR? Okay. Yeah, that's false. Perfect. Because there is a higher amount of creatinine than you would expect from just filtering, it would be an overestimate of GFR. So the ideal marker is inulin. This is because it's freely filtered, not reabsorbed or secreted. It's inert, so it doesn't react with the tubule, and it's not synthesized, broken down, or accumulated. But again, creatinine is used in clinical practice. So next question, we're moving on to the proximal tubule now. Okay, lovely. Show the results. Yeah, perfect. So it is that sodium and water reabsorption are isotonically reabsorbed. Sorry, that sodium and water are isotonically reabsorbed. It wouldn't be an apical NAK ATPase which sets up the gradient for solute reabsorption. It would be a basolateral one. And Na and Cl are not reabsorbed one-to-one early in the tubule. It's later in the tubule that there is reabsorption of sodium with chloride. And with regards to the phosphate, you actually need to secrete phosphate as a buffer to pick up the hydrogen ions, so it's not all reabsorbed for the system. Okay, so what's happening in the proximal tubule? There is this principle that early in the tubule, there's this bulk handling, and then later on, there's more fine tuning and regulation of what's being absorbed or secreted. So the adaptations in the proximal tubule are that there is a large surface area because of this microvilli brush border. The epithelium is leaky, and there is a good drive to reabsorb many solutes produced by the NAK ATPase, which is basolateral, and that generates a large sodium gradient for active transport. So what is secreted and reabsorbed here? Organic anions and cations are secreted. So for example, para-aminohippuric acid and penicillin will use the same transporter to be secreted. So that's just a syllabus point there. And what's reabsorbed is the water and salt. So as we mentioned, isotonically, about 67% occurs here. So that's really some bulk handling, and that's through osmosis. You also have the co-transport of amino acids, glucose, and phosphate. And these are all very important solutes to reabsorb, as you can imagine. Amino acids and glucose for your nutrition, using it for your metabolism, and phosphate is involved in so many processes in the body. So these are absorbed through secondary active transport. We also have the sodium hydrogen exchange system, which allows for a bicarbonate reabsorption, and there will be a basolateral symport system with sodium to bring in those bicarbonate ions. Later in the proximal tubule, it's really sodium and chloride which are reabsorbed, as most of the rest of the stuff has been reabsorbed earlier, so that there's still quite a high concentration of chloride to be removed or to be reabsorbed. So just focusing in on glucose transport, as I mentioned, it's co-transport which is driven by the sodium gradient. Apically, you have the SGLT co-transporters. Early in the proximal tubule, you have the SGLT2, so that's one sodium for one glucose. However, later, glucose becomes more sparse, and you have to spend more sodium ions to retrieve those glucose particles. And then basolaterally, you just have the GLUT channel, which allows the glucose to enter the system. So an important concept here is that the SGLTs can reach maximum capacity where they can't take any more glucose. once that's reached, you reach the carrier capacity, and the glucose, which can't be reabsorbed, will be peed out. So that's why you get sweet smelling urine, and that's seen in diabetes mellitus. So there's a little pathology point for you. Okay. So next question. Oh, sorry. We'll just move back one. Okay. So now that we've covered clearance and glucose transport, what would the clearance of glucose be in a non-diabetic individual? So in the healthy state. Let's see. Perfect. Yeah, it is 0. Because you wouldn't be expecting to have any glucose in the urine. So yeah, moving on. Now we're going to move on to the loop of Henle. So I'm actually going to move back there because I've included the answer to the question. But which of the following is true about the vasorecta? Head over to Socrative and try and answer that one. Okay, let's get those results. Yeah, so the vasorecta does not have a high hydrostatic pressure. It actually has a low hydrostatic pressure to not remove, to not wash out that medullary concentration. It is essential for the countercurrent exchange system, but it doesn't generate the gradient within the medulla. I'm going to explain that in the next slide. And the vasorecta is not impermeable to solutes. In fact, it's very permeable. It can reabsorb solutes. So within the loop of Henle is the urine concentration. And it's important to understand the role of the countercurrent multiplier effect within this. So unlike the proximal tubule, the resorption of water and solutes is split. So there's selective permeability at different segments of the loop of Henle. In the descending limb, it's permeable to water, but not to solutes. And the ascending limb, it's permeable to solutes, but not to water. So now that we have this set up, the countercurrent multiplier effect occurs in steps based on the selective permeability. There are 2 gradients to consider here. There's the transmural gradient, so that's the gradient between the tubule and the medulla, and the axial gradient, so that's the gradient along the length of the loop of Henle. So to start with, we're going to start on the right of this picture here. In the thick ascending limb, the NKCC absorbs sodium, potassium, and chloride to create a transmural gradient of up to 200 milliosmoles, and that's an active process. So because this occurs, the fluid within the tubule becomes hypotonic, it's losing its solutes, and the medulla becomes hypertonic. This allows the hypertonic medulla to draw water out from the descending limb, which, as you remember, is permeable to water. Oh, sorry, that's 2 ones. But yeah, this is the step number 2, where fluid is now already hypertonic when it reaches the bottom of the loop, because you've removed some of the water. And that means that the medulla can become more hypertonic because there are many solutes to within the tubule, which can exit through the NKCC. And so here's where the vasorecta fits in. it maintains the gradient which has been established, so it doesn't wash out all the solutes that have been accumulated in the medulla. And what contributes to the medullary gradient is the urea, which is absorbed through a passive process. And there are UT1 transporters in the inner medullary areas specifically, which allow for the urea, which hasn't left the tubule yet, to follow the gradient. Okay, so moving on from that, we're now going to talk about sodium regulation. So the extracellular fluid volume is largely determined by the sodium concentration, because water follows sodium. So the systems we're thinking about controlling the sodium are the renin-angiotensin-aldosterone system and the natriuretic system, which opposes this. So if there is lower volume, a lower ECF volume, the cardiopulmonary receptors within the vessels and the baroreceptors will pick this up, and this will stimulate the renal sympathetic nervous system to activate the renin-angiotensin-aldosterone system. In addition, as we mentioned before, the low flow to the macula densa, so that's low, that's a proxy for low ECF volume, activates the secretion of renin. So because this occurs, angiotensin will increase the activity of the sodium hydrogen exchanger within the proximal tubule. And it will also increase the secretion of aldosterone. Aldosterone acts further on in the tubule, and it is a steroid, so it acts more slowly through DNA transcription of proteins. Specifically, we're thinking about the ENaC channel, which reabsorbs sodium. So there's upregulation of the ENaC channels, and the potassium channels, which results in more sodium resorption and more potassium excretion. To oppose this whole system, when there is high volume within the ECF, for example, this can be sensed by stretch within the atrial cells of the heart, and then ANP will be released, and just basically ANP will counteract all of the effects we've seen here. It increases sodium excretion, hence the name natriuretic. So it is anti-renin-angiotensin and renin-angiotensin aldosterone. It increases the GFR so that you can get more salt out, basically. And it's also anti-ADH, which is a little crossover with water regulation. So now we're just going to consider water regulation, separate from salt regulation. So there are two big mechanisms to think about here. Your ADH, so antidiuretic hormone, is released when there is a 2% increase in osmolarity. So that's really not much. It's a very sensitive system. And this is detected by the OVLT and the PVN, so that ADH can then be released from the posterior pituitary. Where ADH acts is on the V2 receptors for osmoregulation and the V1 receptor for the vasopressor effect. So that's why it's also called AVP. But that would be for higher concentrations of ADH. V2 receptors are for the low levels of circulating ADH. This is important to have in the system so that you can insert aquaporins in the luminal membrane, because they're continuously being removed. So it's a very dynamic system. You have to keep putting those aquaporins in so that you can absorb water from the collecting duct At the collecting duct portion of the tubule, it's a tight barrier, so you really need these aquaporins to allow the water to enter. The ADH also activates and inserts urea transporters within the inner medullary collecting ducts, which, as you remember, was linked to producing a greater medullary concentration and drawing more water out. And if the ADH secretion is not functional, then that would be a central diabetes insipidus. So you're not getting that water resorption that you need to preserve water. And if the kidney is not responsive to ADH, that would be nephrogenic diabetes insipidus, which is harder to treat because you can't just give ADH because the kidney is not responsive to it. And then thirst is the other mechanism for osmoregulation. So if there is an increase in osmolarity, you're going to want to increase your uptake of water. So there's the hypothalamus thirst center within the CNS. In addition to this sensitive regulation, both ADH and thirst systems can be activated by a large drop in extracellular volume. So you can see that water and salt regulation are connected. Next, I've just included this really nice diagram, which I think could be very easy to draw in an essay, for example, where it shows the difference between, the difference between drinking a ton of water and drinking a ton of isotonic solution. If you drink a ton of water, it will rapidly be regulated. If you drink a ton of isotonic solution, there will be more slow regulation. So that's based on the aldosterone slow effects, which we saw with the salt regulation. And I just pointed out here that when you drink, you actually inhibit ADH secretion briefly. So that's why you might see a little increase in diuresis. I know that you have a different lecture for the acid-base balance, but I've just included this slide for your notes just to bring home the point that the kidney is always removing acid from metabolism and the our diet rich in amino acids and fatty acids. So the kidney's role is to remove 70 milliequimoles per day, and there are the hormones which we've mentioned which alter this function. So angiotensin 2 acts in the proximal tubule. And sorry, that was meant to be aldosterone. Aldosterone acts in the distal tubule for finer regulation. So that can be used for your notes when you're looking over this. Okay, so that was a lot of listening to me talk. Let's go back to Socrative. And now we're moving on to diuretics, which is quite a nice succinct topic. Okay, lovely. Yeah, so our potassium-sparing diuretics are amiloride and spironolactone. I'm just going to explain this based on where the diuretics act. So basically, in the proximal tubule, you can have the mannitol, which is an osmotic diuretic, and that will just basically act very simply by drawing more water into the tubule. Whereas the acetazolamide, it's not a very useful diuretic, but theoretically what it does is it interferes with the carbonic anhydrase enzyme, and it prevents bicarbonate reabsorption. But this is not used as a diuretic in practice. Then moving on to furosemide. This is the most potent diuretic, and you can remember that by thinking that furosemide sounds like ferocious, so it's a very strong, potent effect. And this is the inhibitor of the sodium-potassium chloride cotransporter in the thick ascending limb. And so this disrupts the osmotic gradient and less water is reabsorbed. The side effects of such a potent diuretic would be hypokalemia and volume depletion, so it has to be used with caution. Then moving on further into the tubule, you have bendroflumethiazide or other thiazides. It is slightly less potent because there's less volume and salt to play with at this stage of the tubule. But by that token, it is also less potassium draining. Then we have the two potassium-sparing diuretics. These act late in the tubule. Amiloride acts directly on the ENaC channels, so that's preventing sodium resorption. And spironolactone is an antagonist of aldosterone. So both of these are potassium sparing because of the late stage at which they interfere, and it doesn't prevent, it doesn't interfere with the potassium transport so much. Okay, so that's that for diuretics. I think it's good to know the names of them and know where they act for your exams. And now we're just briefly going to move on to the bladder and incontinence. So we're going back to, so I've got a little bonus question in here, which isn't linked to the bladder, but we'll give that a go. Okay, lovely. Yeah, so basically this is to do with the hormones within the kidney. And we want to know which of the following is not true. Renin is produced by the cells of the afferent arteriole, that's true. Aldosterone is not secreted by the kidney. So that one is false. And ANP is released from the atrial cells of the heart. And angiotensin 1 is converted to angiotensin 2 by ACE from the lungs. So now, I'm going to move on from that. That was well answered. And we will talk about the bladder. So we're back on Socrative again for our final question. Again, you can select several responses. Okay, yeah. So when you're emptying the bladder, yeah, I'll talk through this in the next slide. How you can remember the innervation of the bladder is by a little rhyme. So T10 to L2 helps you go to the loo, and that's parasympathetic. Oh, sorry. Sorry, that's sympathetic. And so what we're looking at is we have the detrusor muscle with the B3 receptors, which are stimulated by the sympathetic system, and the M3 receptors, which are stimulated by the parasympathetic system. These oppose each other, and there is additionally somatic control from the pudendal nerve, which acts on those quick nicotinic receptors for the external sphincter, which is controlled by the pelvic muscles. And the somatic control originates from the same spinal nerves as the parasympathetic nerve. So there are 2 drugs to know for this. If a person is in urinary retention, you want to relax the internal sphincter, and that's opposing the sympathetic nervous system, and that would be acting on alpha-1 receptors. The other drug that can be given is if there is an overactive bladder and you want to relax the detrusor muscle, you give antimuscarinics, so that's acting on the M3 receptor. And those are the 2 pharmacologically relevant things we have for this urinary system. I hope that was clear. Thank you for participating. That is the end of the presentation. Yeah, so
Brilliant.
thank you.